This is Neil Halsey, and today we're going to talk about how vaccines. I want to make certain that my presentations are not misunderstood. We all recognize that vaccines have had an enormous impact on public health, and many of the diseases that were once very common in most of the countries that we reside in have virtually disappeared due to the widespread use of vaccines, and smallpox has been eradicated. But we do need to recognize that vaccines do cause adverse events. Most of these adverse events are mild. Serious adverse events are generally at a rate of about 1 per million for most vaccines. Our responsibility in public health and those involved in vaccines in any way is to make certain that we make the process of vaccination as safe as possible. Understanding how vaccines cause adverse events, the pathogenesis, is very important because if we have an understanding of the mechanisms involved, we can often reduce the risks that are associated with vaccines. I divide the pathogenesis of adverse events into 6 different categories. I'm certain you'll find other methods of reporting adverse events by organ system and so forth. But in terms of understanding the pathogenesis, I think it's helpful to put them into these categories. First, the injection process itself can lead to adverse events. Contamination of vaccines at multiple different points can cause serious infections. Replication of a live vaccine agent can cause adverse events such as fever, and we'll talk more about that in a while. Sometimes there's a direct effect of an individual component of a vaccine that causes the adverse event. The most common method of causing adverse events is through the host immune response to an individual vaccine component. We also need to recognize that the pathogenesis of some adverse events that have been shown to be causally related to vaccines is not yet known. Syncope or fainting is a relatively common adverse event following vaccines, and the rate of fainting is higher in adolescents. In recent years, we've added adolescent immunizations, and we've seen an increase in the rate of fainting. This slide depicts the incidence of syncope or fainting by age group, and note that the highest rate is in adolescents, much higher than in younger children, and we don't even have data on the youngest children because we don't see much in terms of fainting in those. This is a summary of reports to the Vaccine Adverse Event Reporting System in the United States, showing just the number of reports of syncope by age and gender. Slightly higher rates in females as compared to males, females in pink here and males in blue. I said rates, but actually these are numbers. We don't have denominator data in this report, but we recognize that we give far more vaccines to children under 6 years of age than we do at adolescents, but we see higher numbers of reports of fainting at adolescents. The time from vaccination to onset of syncope is usually just a few minutes, most commonly in the first 5 to 10 minutes. They can occur 30 minutes or even up to an hour after vaccination. Falls associated with syncope can lead to serious head injuries. In the United States, some of the largest compensation that has been given to individuals with injuries are due to long-term neurologic sequelae from serious head injuries. And there are at least 2 deaths now that have been documented associated with syncope following vaccines. I have been involved in trying to investigate half a dozen automobile accidents that have occurred in individuals who received the vaccine and either jumped in their car or they received the vaccine, usually influenza vaccine, in clinics where they think it's safe to give it just in the shoulder as people drive by. I'm opposed to those programs and don't think it should be done. Injuries associated with fainting are preventable. Waiting 15 minutes, preferably in a sitting position, has been shown to decrease the rate of adverse events. There are studies underway now to determine if increasing hydration, especially in adolescents, might reduce the risk of fainting. Jonas Salk, the developer of the inactivated polio vaccine, is credited, at least I credit him, with showing people how not to give inactivated polio vaccine, which should be given intramuscularly. And unfortunately, these pictures and others have led others to give it in the wrong location. It should be given in the deltoid. Giving it below the deltoid in this area can lead to nerve damage with some vaccines, as well documented with anthrax vaccine. We also see in some of the posters on promoting vaccines, this is tetanus toxoid. This was on the UNICEF website for 3 years, giving it too low. I believe in this situation, the woman just didn't want to bare her shoulder to get the vaccine. You have to do that. It should be given the deltoid. Giving it too high can also cause adverse events. We've seen reports of shoulder injury in individuals who receive the vaccine very high in the deltoid muscle. Underneath the deltoid is a subacromial bursa, and if you give it in the top third of the deltoid, you can hit that subacromial bursa and get long-term inflammation. You can also see in some of the elderly patients who have very thin deltoid muscles in the top third, you can go right through the muscle and hit the bone, as was done in this particular case, leading to significant inflammatory changes. Ian Cook in Australia has published a very nice review article on this and developed a method to help eliminate this problem. If you ask the vaccine recipient to put their hand on their hip, it actually helps bunch up the muscle, the deltoid muscle, a little bit, and it moves the nerve that sometimes is damaged by injection. And then you put your thumb at the bottom of the deltoid and you put your index finger at the acromion process, the top of the deltoid, and just inject at the midpoint. You will always give it in the middle third of the deltoid muscle. With infants, we recommend intramuscular immunizations in the anterior lateral thigh. I don't believe we should be using the buttocks for immunizations. There are rare sciatic nerve injuries in adults associated with giving inflammatory materials, and some of our vaccines do cause inflammation. There's also decreased immunogenicity. When vaccines require reconstitution or mixing two different components, mistakes are made, and these mistakes are made in all countries. This is a recent report in the United States of a two-component meningococcal quadrivalent vaccine where you reconstitute the lyophilized meningococcal A component with a liquid component that has the CYW. We now have at least 400 reports of administration of only one of the two. People just get confused, in spite of what it says on the label. People administering vaccines don't always carefully read the labels. Measles vaccine is lyophilized, and it comes with a separate liquid diluent, which is really just sterile water, and different manufacturers prepare this in different ways. But because it requires reconstitution, it leaves room for errors. I've been involved in 2 clusters of adverse events associated with sudden collapse and death in Latin America and Asia, but they've occurred in every continent. The primary means by which this has happened is inadvertently picking up a medication, usually a paralyzing agent, such as succinylcholine, Pavilon, or pancuronium bromide, which are used in anesthesia, get mistaken for a vaccine diluent. In the 2 situations that I've been involved in, the diluent vials look similar to the vaccine vials. They're the same size, had the same kind of printing on them, and again, the individuals giving the vaccines didn't read the labels. And the big mistake was storing drugs in the same refrigerator, sometimes even on the same shelf that the vaccine diluent was stored on. Should be stored separately, and guidelines from WHO and elsewhere call for refrigerators that only have vaccines in them. These problems continue to occur. In Syria, in 2014, another paralyzing agent, atracurium, was used to reconstitute measles vaccine that led to 15 deaths. So this requires constant vigilance and careful supervision and training of individuals administering vaccines. Bacterial contamination of measles vaccine has occurred in many countries. There are about a dozen reports of clusters or individuals of usually children who have died. The most common bacterial agent that's associated with this contamination is Staphylococcus aureus. The problem that has occurred in the last decade, or actually 2 decades, has been the reuse of the same syringe for reconstitution of 10 or 20 dose vials. The individuals involved in these outbreaks had understood to give a fresh needle and syringe with every injection, but they used an individual syringe for drawing up the vaccine diluent and putting it into the lyophilized vaccine and then just recapped it and set it aside. Well, you can introduce a small number of bacteria with that process, and because there is no preservative in measles vaccine, organisms such as Staph aureus can multiply and get to very high concentrations. There's also inappropriate storing, sometimes overnight, of the vaccine, sometimes just for a few hours after reconstitution, but these bacteria can grow well. It's a very good growth media for the bacteria. This problem has also occurred with yellow fever vaccine, BCG, and DTP. These are all contamination by healthcare workers after opening the vial, not vaccine that was contaminated in the production process. This happened in 2015 in Mexico, where another staphylococcal organism, a much lower virulent pathogen, Staphylococcus hominis, contaminated multiple-dose vials of hepatitis B vaccine. We don't have the details. I haven't seen this published, but it was widely reported in the news media. There are a number of mechanisms that are injection related. I've covered fainting, injury to tissue, inappropriate diluents, and contamination, but we also can see bleeding in children who have low platelet counts for whatever reason at the site. Transmission of bloodborne pathogens should be a problem of the past. It's been covered by others in this talk, and if we adhere to guidelines, we shouldn't ever see that again. Provocation polio is an event that occurs in children who may be in the middle of a polio outbreak, wild-type polio. They're incubating the organism, it's multiplying, it's in their bloodstream, and then if you get an injection, or especially multiple injections in the same limb, that can predispose to paralytic polio because that provides a point for the virus to enter into nerve endings that get damaged by the injection. There are a number of vaccine factors that affect the risk of adverse events, the type of vaccine, whether it's live or killed. We'll show examples of some of those later. The strain that is used to make a vaccine can influence the rate of adverse event, documented most clearly with live vaccines, but now there are examples with inactivated and subunit vaccines. The degree of attenuation of live agents can influence the rate of adverse events. The dose, the amount we give, the presence of adjuvants often increases the risk of especially local adverse events. We'll talk later about a different type of an adverse event that may be related to the adjuvant. Preservatives, stabilizers can contribute to adverse events, allergy being the most common one. How pure the vaccine is can change the rate of adverse events. The route of administration. Also now we have information on other vaccines being administered simultaneously and with certain situations can increase the rate of fever and perhaps some other adverse events. Bacteria are complex structures with many different components, most of which we don't need in order to induce a good immune response that will protect against disease. We learned that with comparing the whole cell versus acellular pertussis vaccines, DTP or DTWP for the whole cell and DTAP for acellular pertussis. And many different studies showed that the rates of fever, swelling, pain, and fussiness were all much lower with the acellular products as compared to the whole cell. I won't get into the issue of the different protection levels with these, but just to illustrate the point that there are many points in the whole organ, many parts of the whole organism that are not needed to induce protection against disease. In 2010 and 2011, an observation was made, initially in Australia, documenting that a certain vaccine made by CSL was associated with higher rates of fever in young children than vaccines made by the same company, a monovalent vaccine shown in the left-hand bars, and higher rates than observed with other influenza vaccines that were being used. Subsequent investigations by the manufacturer, to their credit, has identified a particular protein in the vaccine that appears to have been responsible for inducing higher levels of inflammatory cytokines, which then stimulated higher rates of fever in young children. No real problem in older children and adults, but just in young children, illustrating an age-related difference that was there. And this was apparently caused by differences in the manufacturing methods that led to a particular heat labile viral component in their vaccine that wasn't in other vaccines, and inadequate splitting of these subunit influenza vaccines. The most interesting thing, I think, is that there were differences in viral strains that led to differences in the rate of fever with these. This slide depicts the rate of febrile seizures in the first 2 days after administration of influenza vaccine, is depicted as TIV here, and then pneumococcal conjugate vaccine, the 13-valent, depicted as PCV13. With influenza vaccines, there's a very small increased rate of fever in children. The horizontal axis on this slide is age in months, and the vertical axis shows the incidence of febrile seizures. It's a large population-based study done in California in the United States. So inactivated influenza vaccine, a small increased rate of fever or febrile seizures. Pneumococcal conjugate, a small increased rate. But when you give them both together, there's more than an additive effect. There's a synergistic effect, most likely through the induction of inflammatory cytokines, and it's still under investigation, but it's been documented now in other populations as well. The degree of attenuation of live agents I mentioned before is a factor. This slide depicts the serial passage of initially a measles vaccine isolate that was obtained in 1954 and then passaged in human kidney cells and then primary human amnion cells, then chick embryo cells, to the product that was licensed in 1963, the Edmondson B vaccine. When studies were done before they reached this degree of attenuation, there were much higher rates of fever associated with attempts to give that vaccine to individuals. That initial Edmondson B vaccine is shown here in terms of the rates of fever greater than 103 degrees Fahrenheit. I think that's 39.4 in centigrade, and the rates of rash. On the left-hand bars, you notice that natural measles associated with close to 100% rates for both of the fever and the rash. The Edmondson B vaccine associated with significantly lower rates, but still 50% rate of rash and 30% rate of high fever was unacceptable. So the vaccine was administered with what was called gamma globulin at the time. Human immune globulin is the term we use now. And that led to a product that was very acceptable. Subsequently, 5 years later, further attenuation led to a product that is now widespread use throughout the world with much lower rates of fever and rash. If you actually give that vaccine with immune globulin, You can lower the rates of fever and rash, but you also lower the take rate from the vaccine because you've blocked the replication. And so we don't give this vaccine with immune globulin. We can illustrate the rates of fever here in one of the early slides that was done that led to licensure of the Edmondson B vaccine. The red line with the yellow squares is the rates of fever by day after vaccination for children who were susceptible to measles, and they received the Edmondson B vaccine plus that small dose of immune globulin. You note that this study started with healthy children with no fever, but there was an increased rate of fever in the 6 to 10 days after vaccination as compared to baseline and as compared to children who didn't get vaccine, shown in the blue line. They just got the immune globulin, or children who were already immune to measles. So this illustrates several points. There's an incubation period, a delay from the time of vaccination to the onset of the fever due to the replication of the vaccine agent, and also that people who are already immune really don't have an increased rate of fever like you see in the susceptible children. More recently, interesting studies have been done showing this same increased rate of fever after the first dose on the left-hand slide and the second dose on the right-hand side, where we don't see an increased rate of fever after measles, mumps, rubella, and varicella vaccines. As shown in the circle, the rates of fever were higher for children who had MMRV as compared to children who received these vaccines separately, so giving them in a combined vaccine led to slightly higher rates of fever and febrile seizures in other studies. But the second dose doesn't lead to this increased rate of fever. Why is that? That's because 95 to 98% of children are immune from that first dose, so you don't see the replication of the vaccine agent and you don't see an increased rate of fever. We see other complications associated with live vaccines. These are data on rubella vaccines that were in use in the United States, Europe, and other countries. And a comparison study done actually in 1982 showed that there were significant differences in the rates of joint symptoms, joint pain, arthralgia, or arthritis, either one combined together here, 35 to 63% with the HPV-77 dog kidney vaccine, lower rates with some of the other vaccines. It was the adverse events that, as well as evidence that these other vaccine strains were less effective than the RA27-3 vaccine, and that has replaced the other vaccines in most countries of the world. These joint symptoms occur at different rates in different ages. These are all females, and you note that with increasing age, there's an increased rate of joint pain. We don't understand what's going on here and why it is, but it's been well documented, so that 50% of susceptible women who are over 24 years of age have some joint pain associated with rubella vaccines. The rates in females are 4 to 5 times higher than the rates of males in individuals 18 to 30 years of age. This also occurs with some inactivated vaccines and with yellow fever vaccine. Females have higher rates of complications than males. Gender is a factor. So what's the pathogenesis of the joint pain following the vaccines? The arthritis with the HPV-77 vaccine, we're pretty certain is associated with the virus actually being in the joint and causing an inflammatory arthritis. Similarly, the same thing has happened with the recently studied Ebola vaccines based upon the vesicular stomatitis virus, parent strain. They've isolated that virus from the joint fluid. But with inactivated vaccines, there is no replicating agent. And we believe that this is due to stimulation of inflammatory cytokines and different rates of susceptibility by gender. This ends the first part of this presentation on pathogenesis of adverse events. Make sure you listen to the second part of this presentation.